Nursing Care of Eating Disorders. Module 1. Weight Bias, Stigma, and Early Recognition. Eating disorders are among the most lethal psychiatric illnesses. They are not trends, not phases, and not attention-seeking behaviors. They carry some of the highest mortality rates of any mental health condition, due to both medical complications and suicide. As nurses, we must recognize them early, not when someone looks sick, not when labs are critical, but when subtle warning signs begin. Early recognition changes outcomes. Eating disorders occur across all body sizes. Someone in a larger body can have severe restriction and medical instability. Someone in a smaller body can appear well, but be critically unstable. A typical anorexia nervosa includes all features of anorexia except low weight, and it carries the same medical and psychiatric risks. Families are not the cause. In adolescence, family-based treatment is first-line care and improves remission rates. Families are essential partners in recovery. Eating disorders affect all genders. Males are often underdiagnosed and may present later with higher mortality risk. These illnesses are biologically influenced, psychologically complex, and medically serious. Do not rely on appearance. Weight bias delays diagnosis. Research shows that both healthcare providers and treatment systems can unintentionally reinforce stigma. Assuming weight equals health is clinically inaccurate. Weight-inclusive approaches focus on behaviors, medical stability, and psychological health rather than weight alone. Use person-first language. Say a patient with anorexia nervosa, not an anorexic. Your tone sets psychological safety. You are assessing patterns, not just numbers. Look for rapid or significant weight change, rigid food rules, avoiding meals, excessive exercise, GI complaints, cold intolerance, fatigue, hair thinning, dizziness or fainting, orthostatic changes. Orthostatic red flags include heart rate increase greater than 20 beats per minute when standing, blood pressure drop greater than 20 systolic or 10 diastolic. Amenorrhea can be present in adolescence, but it is no longer required for diagnosis under DSM-5 criteria. Do not rely on one symptom. Assess the whole picture. Medical instability is priority. Severe bradycardia, particularly heart rates less than 50 in adolescents or less than 40 in adults, is concerning. Watch for hypokalemia, hyponatremia, hypophosphatemia, and hypomagnesemia. Electrolyte shifts can lead to arrhythmias and cardiac complications. Refeeding syndrome is a life-threatening risk when nutritional intake resumes. If a patient presents with syncope, severe orthostatic instability, marked bradycardia, and electrolyte abnormalities, medical stabilization comes first. Psychiatric and medical care must be integrated. Patients often present for something else: anxiety, depression, GI complaints, fatigue, or electrolyte abnormalities. You connect the dots, you ask gently and neutrally, how do you feel about your eating habits? Has your weight changed recently? What role does food play in your stress? Validated screening tools can support your assessment. The SCOFF questionnaire is brief and evidence-based. A score of 2 or more warrants further evaluation. Clinical judgment and structured screening work together. Stay calm, stay curious, stay non-judgmental. You may be the first clinician to recognize the pattern. Your role includes using weight-inclusive language, focusing on well-being rather than body size or weight as the primary marker of health, eliminating stigma, monitoring vitals and labs, assessing orthostatic changes, advocating for medical evaluation, initiating referrals, involving families appropriately, and collaborating with dietitians, therapists, and psychiatry. Eating disorder care is multidisciplinary, but early detection often begins with nursing assessment. Think NCLEX. Which patient is unstable? The patient with potassium 2.8, the patient with symptomatic hypophosphatemia, the patient with severe orthostatic changes, the patient with heart rate in the 40s. You prioritize safety. You stabilize before you educate. Emotional support matters, but physiological safety is immediate priority. Eating disorders are complex. They intersect biology, psychology, family systems, trauma, and culture. Your responsibility is not to judge. Your responsibility is to recognize, see beyond appearance. Assess without bias and protect medical stability. Engage families appropriately. Refer early. You are not assessing weight, you are assessing risk.